topic is on the correction of distance and near vision. We have seen the monovision, and our segment is for the after cataract surgery. So nothing is perfect. Everything has its own advantage and disadvantage. Accommodative IOL is now an emerging trend in presbyopic correction during cataract surgery because the demand of the patient is increasing day by day. They don't want the glasses, as you see in the refractive also. Phakic patient also needing that, not need glasses. So basic aim is to ability of to near work without glasses. Patient needs, as Arvind mentioned, there are different work with the near, intermediate. There is the Helmut theory of accommodation, contraction of ciliary muscles, relaxation of zonules that changes the spherical shape of the lens, increase dioptric power of the lens, and that give the clear near vision. On this basis, the accommodative lens is working. There are the multiple design. Earlier we just skipped that second design, plate F 6, third. Now that was the crystal lens model 4445. Then come the human optics, foldable single piece IOL with hinge haptics, significant but varying accommodative response. Now the latest is the crystal lens, high definition. It works on the both principle. As a contraction of ciliary muscle, movements forward in the response to ciliary muscle contraction, the dynamic power of the intraocular lens increases. And another is the ciliary muscles contraction, optics as well as haptic bench forward. That give another increase in the near power, and that leads to steeping of the lens and increased accommodative impact. So it works on the both way, dynamic in shift of the intraocular lens and arching of the intraocular lens. Here is the animation, how it moves forward, and for near work is overall shifting of the lens and changing of the. So it provides a single refractive surface, provides a seamless point of the focus far to near in both eyes. In contrast to multifocal IOL, which is dual simultaneous focus, or monovision, where one eye is set for distance and one for near. The design characteristic of high definition crystal lens, there is a hinge on the optics, as I mentioned, that enhances the forward movement of intraocular lens during ciliary muscles contraction. They have the large haptics. You have seen that they are the large haptics, so their attachment with the sulcus and capsular bag is much more. IOL placed deep within the capsule, more room for the lens movement. Optic thicker in central 1.5 millimeter, that in periphery, and that increases the arching effect. So it features a unique change in the central asphericity of the optic that produces an optic optimized for reading. This is the abrometric evaluation for distance, and that you see that there is increasing near power in the central only. This is for when this is for distance, and when this for the periphery is almost same, but there is much increase in the near power in the central area. This is how the focusing in an accommodative, there is focus for this clear focus, so there is no loss of the contrast as compared to diffractive multifocal, refractive multifocal. There is, you can see that there should be contrast anyway. That requires selection of the, because there is no toric accommodative lens available, so corneal astigmatism with more than one diopter should be avoided. More than 22 or high myopic or high hypermetropic, because then the power calculation varies many times in that cases, so your perfection will not be there. Pupil size should be more than 6 mm, and any other optical ocular pathology. Another important point is intraocular exclusion, because they work on the whole bag structure. If your rhexis is gone out and your rhexis is broken, then effect of the accommodative lens will be lost. So you have to abort the procedure at this junction, and that everything you should be conveyed to the patient during counseling. Posterior capsular tear. If in the bag implantation is not possible, either you have used CTR, so because then if CTR stretches the bag and the effect of the accommodative lens will not be there. Biometry, SRKT or A constant is 119. Manual K reading is best because that due is from the periphery. size of the CCC should be larger than 6 mm or around 6 mm, so it gives the space for the movement of the optic forward and backward, because if it is smaller rexis 5 mm, that it will be difficult, sometimes it will prevent the optics movement forward. You have to put one drop of atropine at the completion of surgery. You keep the muscles relaxed for 15 days, so the lens fixes for the distance, and you start reading after 15 days. So ask the patient to not to read for 15 days. It is FDA approved. Power range available 10 to 33, and in this 0.25 step is available. Performance depend on the achieving and maintaining a good refractive outcome. Accommodative potential is achieved after complete capsular bag shrinkage. So it will take around 2 months to develop the complete. Now, downside of the accommodative lens, percentage of patient reading at 20 or 25 is level not as high as multifocal, as Dr. Harbans mentioned, because they may not achieve that much accommodation which 2.53 diopters. Ideally, they achieve around 1.5 to 2 diopter, but they give the very good intermediate vision. Issue with refractive error. Capsular opacity comes earlier with Kestra lens as compared to multifocal, but probably the result after capsulotomy, the effect of the accommodative lens are as good as. Another is the capsular contraction syndrome, jet syndrome. If the full fibrosis occur, the effect of the accommodative lens is gone, but only thing advantage that there is no drawback like the halos, glare and any other thing. Only thing the accommodative potential is gone. There are other lenses in the pipeline, lenses tetraflex, synchrony. This is vegan synchrony lens. This is one of the video. As Dr. Kulin mentioned, that it needs some of the learning curve because the haptics is larger and you have to put that haptics through this rexis, and you are at risk if you have broken the rexis, if you have to withdraw the lens. So better to stent the capsule so you can identify the lens during insertion or capsular axis. Fill this with the viscot, because with the high visc or Hilon, the chances of collapse is much more. So we used to put this viscot in the front of the wound, so there is no leakage of high visc, and only thing that you have to wash it, the special injector. Wound size should be 3.2. We cannot go with 2.8. Should be careful with the injector going deep in the bag, so lower haptics will go down, and with the you may take the help of spatula and hook after. With the help of a spatula, and you can guide this lower haptic, upper haptic into the bag. And you have to ensure that your lens fully in the bag by slightly rotating this. If rotation is perfect, you can one small video. Okay. Sometime your haptics leave the with this plunger you can guide very well. copper haptics sometimes become difficult to put. Here the viscot comes to, and you can guide very well with the bag. Thank you, friends.